Hello and welcome everyone. My name is Melanie Dizon. I'm the Director of Education at the Davis Phinney Foundation. And today we're going to be talking about Parkinson's for primary care doctors and allied health professionals with Dr. Ray Dorsey. Dr. Dorsey, thank you so much for being here today.
My pleasure, Melanie.
Great. I'm going to dive in a minute, but I just want to do a quick tech check for those of you who may not be super familiar with Zoom. If you look at the right, if you take your cursor to the right-hand side of the little Zoom dashboard, you'll see something that says either speaker view or gallery view. If you click gallery view, then you will see both Dr. Dorsey and me right now. If you just have speaker view on, then whoever is speaking at the time is going to fill up your screen. So you can make a choice. It's probably not going to matter too much at the beginning because Dr. Dorsey is going to share a presentation, but when we're doing the Q&A, it's usually a little bit more pleasant to watch two people in a conversation than just my big old head at your screen. The other thing I want you to check out is we have a chat box at the bottom. And if you click on chat, a chat will open on the right-hand side. And at the bottom, you'll see a little blue button. And there is where you'll be able to decide who you want to send the chat to. If you wanted to just go to me and Dr. Dorsey, you're going to pick panelists. If you want it to go to everybody in the webinar, then you want to hit all attendees or something that says all panelists and all attendees. That is the place where I'd like you to put your questions. We don't have the Q&A icon here today. It's just a little bit easier if I get all the questions through the chat so I can monitor that. And how we're going to work it is Dr. Dorsey's going to share a presentation. If something comes up during his presentation that I think that we really need to ask the question about, I will ask that question. Otherwise, we're going to wait. He's going to talk for about 20 to 30 minutes, and then we're going to wait till the end, and we're going to open up for questions. So feel free to put your question in the chat box, and then I can go back when we move to that. Can everybody see and hear me? If so, please type so in the chat so I can make sure we're all good. Just click the chat box and then type a message to me. Okay, that's good. A-okay, we're all up. Awesome. Okay, I hate to like talk into nowhere and be like, wait a second, no one's hearing this. Okay, so we're gonna get started. I'd like to introduce Dr. Ray Dorsey. Dr. Ray Dorsey is a professor of neurology and the director of the Center for Health and Technology at the University of Rochester Medical Center. He investigates new treatments for movement disorders and seeks to improve the way care is delivered for those with Parkinson's and other neurological disorders. Dr. Dorsey completed his undergraduate studies at Stanford University, medical school at the University of Pennsylvania, and business school at the Wharton School. He's also recently co-authored a book with Dr. Boss Bloom and Dr. Michael Oken called Ending Parkinson's Disease. Woohoo, there it is. So thank you so much for being with us today, Dr. Dorsey.
Thanks very much, Mel. Everyone calls me Ray.
Ray, okay, Ray.
A huge fan of the Davis Phinney Foundation, huge fan of Mel and Polly Dawkins, Davis Phinney, Connie Carpenter, Phinney, and the entire group. So really delighted to be here today. I'm going to talk for 15 or 20 minutes, hopefully not too much longer, and then happy to take hundreds of your questions, as many as we can get to over the next hour. So I'm going to share my screen. Hopefully everyone can see it. Mel, tell me if it's okay.
Just, yep, all good.
Beautiful. So what is Parkinson's? Parkinson's is the fastest growing brain disease in the world. The fastest growing brain disease in the world is Parkinson's disease. It's even faster growing than Alzheimer's disease, faster than stroke, faster than epilepsy, faster than ALS. From 1990 to 2015, the number of people with Parkinson's disease worldwide has more than doubled. And from 2015 to 2040, if we don't act, if we don't change our behaviors, including use of pesticides, air pollution, environmental chemicals, and heavy metals, the number of people is going to double again. In short, all of you will see somebody with Parkinson's disease. All of you will care for somebody. All of you will see someone with Parkinson's disease. The question is, will you recognize it? And after this talk, you will. And then all of you will be caring for people with Parkinson's disease. Just to give you how common this is, people like me, middle-aged docs, have a lifetime risk of 1 in 15. So if we have, 30 primary care physicians or 300 if we have 30 primary care physicians, 2 of you are going to develop Parkinson's disease in your lifetime. So this is a huge public health issue, not only for the patients we serve, but for us as individuals. And I'm happy to talk more about ways we can prevent it, including exercising vigorously, limiting exposure to pesticides, getting rid of certain chemicals, testing our well water, and a bunch of other things. But this is really a common disease. The number of Americans with the disease has increased 35% in the last 10 years. So what is Parkinson's disease? Parkinson's disease is best thought of not necessarily as a brain disease, but as a multi-system disease that initially begins actually in the nose and the gut. So the earliest symptoms of Parkinson's disease aren't the classic tremor that you learned about in medical school or in professional schools, but it actually begins with loss of smell and constipation decades before the tremor appears. But the four classical textbook characteristics of Parkinson's disease are arrest tremor, usually in the hand, usually asymmetric, worse on one side or the other. Slowness in movement. Easy thing to do is to have people tap their thumb and index finger, and they will have pauses or a decrease in amplitude as they do it. Cognitive rigidity or stiffness in their arms, usually just felt by feeling somebody's arms, hard to do with telemedicine. And then difficulties with balance or gait. If you watch people at a house of worship, if you see people in an airport, you see people walking on the streets of your communities, you will see people with Parkinson's disease. Parkinson's disease is one, preventable. We can discuss that in great detail, but two, treatable. The underlying causes are thought to be genetic in about 10 to 15%, but that means that environmental factors dominate the causes of Parkinson's disease. Farmers, for example, and those who live in rural communities are 50 to 150% increased risk of developing Parkinson's disease. And pesticides, many of which are nerve toxins, target the parts of the cell that are damaged in Parkinson's disease, known as the mitochondria. They're often fat soluble and they enter the brain. You feed some of these pesticides to mice and they develop the clinical and pathological features of Parkinson's disease. Other chemicals, including a chemical called trichloroethylene, a widely used degreaser used by mechanics, by embalmers, by machinists, by people in the printing industry, are all increase the likelihood of developing disease. And both pesticides and this chemical trichloroethylene or TCE can contaminate groundwater and well water and increase the risk of Parkinson's disease. And people could have had these exposures when they were decades ago, when they were 5 years old, 15 years old as a kid. Three main ways to treat Parkinson's disease: exercise. So vigorous exercise in your 50s and 60s can actually decrease your risk of developing Parkinson's disease by 15-20% or more. And exercise is really beneficial for those with the disease. We'll talk more about that. Medications are also highly effective. Levodopa, which is Parkinson's disease is loss of nerve cells that produce a chemical called dopamine. Levodopa replaces that dopamine that's lost. It's a highly effective medication and almost universally beneficial for individuals with Parkinson's disease. So much so, if people don't get better, it raises a question about whether they have Parkinson's disease. And then surgery for select individuals, deep brain stimulation, can help people with more advanced disease. We'll talk all about that. So I told you that the earliest symptoms of Parkinson's disease are these I'll back up. Some people classify symptoms of Parkinson's disease into the motor symptoms like tremor, slowness in movement, difficulties walking, and non-motor symptoms, depression, anxiety, loss of smell, and constipation. As I said before, Parkinson's disease doesn't begin in the brain. It begins in the nose and in the gut for most individuals. And in fact, the earliest symptoms of the disease, as I mentioned, are constipation, hyposmia, loss of smell, REM sleep behavior disorder, depression, anxiety. And then other symptoms are really, really common in Parkinson's disease: fatigue, pain, urinary urgency, very common, lightheadedness when people stand up, and then later stages, dementia. Similarly, tremor and rigidity are early motor features of the disease, and then common complications of long-term use of levodopa at high doses are involuntary movements, so-called dyskinesias, If you see Michael J. Fox on TV, for example, he often has a lot of trouble sitting still. Those are likely due to dyskinesias. If you keep the dose of levodopa low, you can largely prevent those dyskinesias from developing. However, as the disease progresses, the nerve cells die off, higher doses are often required. So it's a high level of the clinical features of Parkinson's disease. And many times, as I said, the non-motor symptoms occurred before. Now, as you can imagine, many of these symptoms might present to a primary care physician. They might present to an orthopedist with a frozen shoulder. They might present to a physical therapist after a fall. They might present to a speech therapist with softness in voice. So it's incumbent on all of you to keep Parkinson's disease in your mind, because if you find it, you can accelerate the time into which they get appropriate treatment, and in some cases give that treatment yourself, and improve the quality of life of individuals with Parkinson's disease. The typical individual with Parkinson's disease who is diagnosed takes 2 years from the time they develop tremor and the like to actually getting a diagnosis of Parkinson's disease. You can help decrease that time and reduce suffering for individuals with these diseases. And then a large number, hard to say, some parts of the country, some parts of the world, up to 50% or more of people with Parkinson's disease are never diagnosed. So no one ever tells someone that they have a disease that's treatable. Just like you wouldn't want someone with seizures to go on having seizures because if they're treatable, we have medicines to stop seizures. You wouldn't want somebody with Parkinson's disease to go untreated with Parkinson's disease because we know that exercise, medicines, and again, surgery can be of enormous benefit to people. So make the diagnosis. If you're unsure, send them to a neurologist or send them to someone with expertise in Parkinson's disease. So who develops Parkinson's disease? It turns out about 60% of people with Parkinson's disease are men versus women. And we think that's largely because men are engaged in occupations that put them at higher risk for the disease. Men make up 3/4 of farmers, 80% of metal and plastic workers, 90% of chemical workers, 97% of pesticide workers, all of which these occupational risks all increase the likelihood of developing Parkinson's disease. So people grew up in rural areas, so they grew up drinking well water. Well water is often contaminated with pesticides from neighboring farms and is not regulated by the Safe Drinking Water Act. These are all things that we can do to decrease our risk of Parkinson's disease. We detail them in great detail in our book, Ending Parkinson's Disease. You can get it on Amazon. I will tell you more about that later. So let's see, next is other conditions that can mimic Parkinson's disease. So not everything that's tremor or slowness movement is Parkinson's disease. These are a wide range of other Parkinsonian conditions, dementia with Lewy bodies, prominent early difficulties with dementia, multiple system atrophy, prominent urinary and sexual dysfunction early in the course of the disease within the first year, cortical basal syndrome, prominent cognitive difficulties, progressive supranuclear palsy, prominent falls. Essential tremor is a tremor with action. So Katharine Hepburn, for those who are older, had a tremor when she would bring something to her mouth, like drinking a glass of water. People might have it when they put on makeup or when they draw a spiral. You can see like tremor when they're doing it, as opposed to Parkinson's disease where people get small handwriting. People with essential tremor will have tremor when they draw a spiral. And then the other two things, that certain medicines can cause Parkinsonism. Antipsychotics, Reglan and Compazine. Antipsychotics, Reglan and Compazine can all cause Parkinsonian features. Generally reversible. The treatment is not complicated. It's to stop or reduce the dose of those medicines. So avoid Reglan and Compazine, especially for long periods of time. If someone needs an antipsychotic, there are antipsychotics that are less likely to block dopamine receptors like Seroquel, and less likely to cause Parkinsonian features. Treatable, eminently, don't cause Parkinson's, Parkinsonian disorder in your patients. And the essential tremor, also in addition to the action tremor when they do something, as opposed to just sitting there resting, reading a book or watching TV, they can have a tremor in their head or a tremor in their voice. If you sound say E, you'll hear E. You can even hear a tremor in their voice. That's your differential. All right, caring for people with Parkinson's disease. So first, my colleague and co-author, Dr. Boss Bloom, thinks there's about 30 different specialists that can provide services to people with Parkinson's disease. For the sake of space, I think we listed about 10 or 12 right here. So if you're an occupational therapist, you can help people move around and use utensils. If you're a speech therapist, you can help people with the softness of voice. If you're a physical therapist, you can help people with range of motion exercises or balance. If you're a psychologist, you can help people with depression and apathy. If you're a urologist, you can help people with urinary or sexual dysfunction. If you're a gastroenterologist, you can help them with constipation. If you're a dentist, you can help them with their hygiene because they end up having excess drooling. People also have trouble with reading with glasses, and prisms can sometimes help people. So there's a wide range of people who can help people with Parkinson's. Many of you represent many of these specialties, and we're delighted that you're participating in the seminar, and thank you very much for your efforts to help people with Parkinson's disease. So treatment, first one, exercise. Everyone with Parkinson's disease should be exercising. Everyone, period, should be exercising, and everyone with Parkinson's disease should be especially be exercising. Numerous studies have shown that a wide range of exercises, everything from the tango to Tai Chi to running, have all been shown to be beneficial in people with Parkinson's disease. I recommend that patients exercise at least 1 hour a day, at least 1 hour a day. If they have Parkinson's disease, Davis Phinney from the Davis Phinney Foundation, I think he still bicycles with his Parkinson's disease. So we have people doing all types of things with their Parkinson's disease. If I had Parkinson's disease, I would probably exercise 2 hours a day. And these are a wide range of exercises can do it, especially things that improve range of motion. Bring your hands above your shoulders because shoulder problems are very common. Swimming is a great exercise. Aerobic exercise and exercise that improve balance and posture are all great as our flexibility. At least an hour a day if they can handle it for Parkinson's disease. Numerous studies have demonstrated the benefit. Medications, we'll do a brief overview. So Parkinson's disease at a high level is a loss of dopamine producing nerve cells in the part of the brain that's responsible for controlling movement. The most effective treatment for Parkinson's disease is levodopa, which often is, comes with another medicine called carbidopa, which prevents the nausea that's associated with the medicine. And it's generally sold under the name of Sinemet. It's usually 25 milligrams of carbidopa, 100 milligrams of levodopa. You start out at like a half tablet once a day because people can get nauseous, and eventually get up to about 1 tablet 3 times a day, usually 8 a.m., 12 noon, and 5 p.m. because you want to give them the dose during daytime waking hours so they can alleviate their tremor. That's the most effective medicine. If you remember only one thing with respect to medication, is just levodopa. There are medicines that in animal models slow the rate of Parkinson's disease. These are known as Mao-B inhibitors. They slow the breakdown of dopamine in the brain. They're a benefit to individuals with Parkinson's disease. I use these frequently. Dopamine agonists are synthetic dopamines like pramipexole or Mirapex or Ropinirole or Requip. These medicines do help the features of Parkinson's disease. They're less likely to cause dyskinesias, but I generally avoid them because they can cause compulsive gambling, compulsive sexual behavior, compulsive shopping. I've had patients lose their life savings with these medications. I've had people cheat on their spouses because of these medications. If you have people who are on these medicines, I tell them ahead of time that these things can happen. And I ask every single time I see them if they're experiencing it, or almost every single time I see them. Because even if they know about it, they still run into difficulties. So I generally avoid them. I use a lot of Mao-B inhibitors and a lot of levodopa.
Darcy?
Yes.
I just wanted a quick question. This is relevant for right now. Does levodopa, is it effective against conditions that mimic Parkinson's? So some of the ones we talked about before.
So so it's not effective for essential tremor. So it doesn't help you with essential tremor. Essential tremor is treated with propranolol and primidone. So I'm going to show you because everyone's going to get propranolol. So like if you have people draw a spiral, people with essential tremor will draw a spiral that looks like that. So that's essential tremor. That's all you have to do is have them draw a spiral in the right hand and left hand. If they have Parkinson's disease, they'll draw a spiral that looks like this. Small. So it's an easy bedside test. You can do it by telemedicine. It takes all of 15 seconds. It's a very inexpensive test to do. The other Parkinsonian, also levodopa won't work if you're giving people a medication, antipsychotic, that blocks dopamine receptors. So that would be kind of silly to give someone medicine that blocks dopamine receptors and then give them levodopa at the same time. So that wouldn't be wise either. Other Parkinsonian disorders, cortical supranuclear palsy, multiple systems atrophy, cortical basal ganglionic degeneration, these can have some modest benefits of levodopa. If you see someone who's got one of those disorders, I personally would punt to a neurologist with no questions asked, because just, they're relatively rare and you want them to be seen by someone who sees lots of patients with them. These medicines do have side effects. They can cause lightheadedness, they can cause nausea. Even though the medicine says to take it without food, I recommend people with levodopa take it with food. In theory, there's a competition between levodopa and protein for absorption. So I tell them not to eat it with a hamburger. They have it with banana or crackers, fantastic. There are a wide range of symptoms of Parkinson's disease, and so these can be treated with other medicines. So depression, for example, can be treated with SSRIs. With cognitive impairment can be treated with medicines like donepezil or Aricept. There are things that can be, but we'll keep this at a high level. Most effective medication for Parkinson's disease is levodopa, also known as cinnamon. Deep brain stimulation. So for deep brain stimulation actually puts the surgical treatment, a neurosurgical treatment. It puts electrodes into the brain. It targets a part of the brain, usually called the subthalamic nucleus, that is inappropriately overactive in Parkinson's disease. When electrodes put in, it disrupts the output of that nucleus and leads to reduction in Parkinsonian symptoms. This thing works well for certain patients. Those who are young, our definition of young is under 75. Those who clearly have Parkinson's disease, so they have Parkinson's disease that responds to levodopa, but they developed those dyskinesias, those increased involuntary movements, or they develop periods where the medicine works well and periods where the medicine doesn't work well, so motor fluctuations. This works well for people whose thinking is relatively well intact because this does not help thinking. It does well for people who are good surgical risks. And perhaps most importantly, you want this done at a center that does a lot of these. Studies have shown that widely for surgeries, that surgical centers that do lots of a particular operation have better outcomes. The same holds true for deep brain stimulation. You don't want this being done by a neurosurgeon who does 2 of these a year. And you don't want this being done under the care of a neurologist who sees patients infrequently. So refer people to the major medical center. The gift of telemedicine is that after initial surgery and programming, increasingly care can be delivered remotely. So again, these are people, 70-year-old patient you've been following for 5 years. They've been done well with levodopa, but now they're getting complications. This is somebody you can consider for deep brain stimulation. Telemedicine. So as Mel alluded to, I spend a lot of time caring for people with Parkinson's disease via telemedicine. We started doing this in 2007 by caring for individuals in nursing homes, and I actually haven't even set foot in a clinic as a doctor since 2013. I'd see almost all my patients over via telemedicine. And so this is the migration of care from hospitals and clinics to home and mobile devices. And the same thing that's happening in banking, where banking, you used to go see a bank teller, and then you went to an ATM, and the ATM was in the bank, and then there was an ATM in your community. But now most of you do your banking at home, or most of you do banking on your mobile device. We think this is the future of care, is to bring care to patients instead of bringing patients to care. And so, everyone's done, or I imagine the vast majority of you have done some form of telemedicine. That's the back of my head. In my office, I'm now at home because of COVID. I see patients in Delaware twice a month. Used to be in a clinic, now I see them in their home. And then I see patients like the McCaskills who live about 300 miles away from me in Saratoga, New York, and I see them in their home. And the nice thing when you see people in their home is you get a cool sense of what their life is like. And so you can see the McCaslins here have a diner. You can look, this is actually a diner set up in their house. They have a red booth here. I don't know if you can see the red booth. You can see the red table that they have. You can see their jukebox machine. I think it's got a quarter. In the background is Betty Boop over here. And so you get an entirely rich perspective on their life. And the McCaslins are in their 80s. And I think he's had Parkinson's for about 10 years. So you can imagine someone like him. It's kind of odd to ask someone with advanced Parkinson's disease to come see me in clinic, and rather we see them in their home. So a plug, buy our book. You can buy it on Amazon. It's like 18 bucks. It's under 18 bucks, I think, right now. If cost is a problem, you will just email us at info@endingpd.org, and we'll send you a free copy. So if cost is a consideration for you and you need it, would like a copy, we will send you one for free. Just email us at info@endingpd.org. Otherwise, we'd be delighted for you to read it. It talks all about the environmental risk factors for Parkinson's. It talks a lot about how we can prevent Parkinson's, advocate for additional resources for it, care for the disease, care for all people affected, and treat the disease with new therapies. We'd love you to read it, and you can go on Amazon and write a review of it. We'd love you to do so. I'm going to take you there right now. So let's see if I'm going to stop the sharing right here just for a second, and I'll share a different screen. And so you can just go to Amazon and you can just purchase the book right now. It's been well reviewed. People like it. $17.89. All the authors, Todd Cho, CEO of the Michael J. Fox Foundation, Michael Oken, a DBS specialist in Boston, the Netherlands. We're donating all of our proceeds to efforts to end Parkinson's disease. We're not taking a penny for ourselves. We're using it to investigate clusters of Parkinson's disease here in Rochester, New York, that we think are potentially due to these chemicals called trichloroethylene and others, so we can prevent people from ever developing the disease. And then in addition, we are hosting a number of webcasts on Parkinson's disease, including we had one with Davis Phinney and Connie Carpenter Phinney that was hosted with Boss Bloom, the senior author on the book. If you go to endingpd.org, you can watch that webcast right after this seminar and learn a lot about Parkinson's disease. We have interviews with people who grew up on farms who developed Parkinson's disease. We have interviews with astronauts who worked with trichloroethylene and developed Parkinson's disease. We have interviews with, I think, speech therapists or physical therapists or other allied health professionals. We have interviews about nutrition and diet and exercise, all there, all free, all available for you to watch. And then finally, we can address one of the great health challenges of our time is Parkinson's disease. In addition to COVID, we have a pandemic of Parkinson's disease that we discuss in the book. And so we can prevent people from ever developing it by banning pesticides like paraquat linked to it, avoiding indoor air pollution, which is a big problem we discuss in the book. Exercise, a Mediterranean diet, and a modest amount of caffeine can decrease your risk of developing Parkinson's disease. So think about those for you yourself. We can advocate for additional resources for research for Parkinson's disease. We can care for everyone affected by the disease and develop new therapies for it. With that, I will stop and turn over to Mel and take any questions that you have.
Okay, great. Thank you so much. Everybody, if you have a question, it would be great if you put, like right before you your question, if you're an OT or a PT or an MD, if you just put it right before your question, then we have a sense of sort of what area you're working in. That would be super helpful. If a nurse or something like that, that would be great. Somebody asked about levodopa and if it's effective for both motor and non-motor symptoms.
Likely, yes. So most of the studies have been around motor, but it is by far the most effective medication for Parkinson's disease. It can help relieve a lot of the anxiety that's associated with Parkinson's disease, the inner unrest, unease that's associated with it. Your patients will love you. They'll think you're the best doctor or best clinician ever if you give people early in the course a low dose of levodopa.
That's great. So a gerontologist, psychotherapist asks, what what do you think about 50 to 200 Cinemet 5 times a day? You said 25, 100 3 times a day is preferable. What's that? I mean, I know a lot of the people that we work with, they're, you know, at some point they're taking 35 pills. Like, so how are you working that?
So I think if you're getting to that area, you really want to be comfortable with Parkinson's disease. The first right expressed in the European Parkinson's Disease Association's Charter for Parkinson's disease is the right to get care from a clinician with expertise in Parkinson's disease. Now, that obviously a lot of neurologists have expertise, but there are geriatricians, there's internists, there are physical therapists, occupational therapists, and speech therapists with a huge amount of expertise in there. I think if you're getting to 5 tablets of 5,200, that means 200 milligrams of levodopa per pill. I do that. I do have people taking that much, but I think I would be wanting to be seen by a neurologist. And we do have people taking that high dose and even higher, but I think at that thing you want to make sure you're optimizing, not making sure you're having food interference, minimizing the potential for side effects, adverse effects that could come at higher doses.
Great. So referral out if you're getting to the point where it's not being managed by.
And just remember, you don't have to, like, you know, sometimes doctors especially feel like they have to solve everything. And sometimes you don't. Even I send people, I can't figure it out. And I send it to a friend or colleague. Even in Parkinson's, I've seen people with Parkinson's that I referred out to friends and colleagues. And that's all I do. So I don't think there's any shame in sending someone to get seen if you feel uncomfortable. Because many times you just don't have the expertise or experience. You know, I don't have a lot of experience in managing multiple sclerosis, so I wouldn't do it.
Right. Someone asked, what are the best resources online regarding environmental hazards? Yes, your book. That's the place to go first because there's a lot of amazing information in there. But they asked what specific well water testing should be done if people are, you know, living with well water.
Yeah. So if you look, there's black pages in our book, and they list the resources for, you know, testing your well water. So you just, since you mentioned well water, we say in our pact to end Parkinson's disease prevent, there is a website, epa.gov/private wells that you can do to make sure that you're drinking clean water. And there's an EPA drinking water hotline that we provide in the book. Many of these resources, again, are available on our website, endingpd.org. But again, we need people to get the word out about the book and about ending Parkinson's disease and preventing people from ever getting it. Because just like COVID, the easiest thing is to prevent people from getting COVID as opposed to trying to treat it. It's much easier to prevent Parkinson's disease than it is to treat it.
Okay. What have you found to be an effective treatment for sleep disorders for people in Parkinson's?
So sleep disorders are almost ubiquitous in Parkinson's disease, beginning with fragmentation of sleep and then something called REM sleep behavior disorder, in which people act out their dreams. So normally if you're dreaming at night that you're being chased by a lion, for example, you're normally paralyzed. But in Parkinson's disease, that paralysis is lost and people act out their dreams and sometimes kick or hurt or even knock over their bed partner. People who have trouble falling asleep, I use low doses of melatonin. If people really have bad REM sleep behavior disorder and are concerned about it and it's bothersome, one, you can separate beds, but if it's really bothersome to their bed partner or something, I use low doses of clonazepam.
Okay, great. An RN and fitness trainer is asking, can you comment on the effectiveness of exercise program focusing on the proprioceptor system?
Yeah, so the big thing is around balance. So proprioception is, you know, having a sense of where your joints are in space. So there's a beautiful study of Tai Chi in the New England Journal of Medicine, randomized controlled trial that showed that Tai Chi, a lot of proprioception training, decreases your risk of falls and improves posture and balance. Yoga and Tai Chi, I recommend strongly to people with Parkinson's disease.
Okay. An RN asks that she says she has a patient who had thalamic stroke, sorry if I'm pronouncing that wrong, and exhibits many symptoms of Parkinson's but no tremor. Is it common with injury to the thalamus to have Parkinsonian symptoms, and would levodopa help?
It can. So rarely strokes can cause Parkinson's. Vast majority of strokes don't, but sometimes depending on the location, they can. In general, levodopa would be recommended at least as a trial, and most people do benefit from it. So if you think that's the cause, then yes. It also could be that they have a thalamic stroke and they just have Parkinson's disease too, and it could be true and unrelated. But unless the patient has extremely strong objections, almost everyone at some point in time in the course gets started on levodopa.
Okay. Have you done much work around protein-restricted diets for people with Parkinson's?
So protein competes, levodopa is an amino acid. Proteins are made up of amino acids. So protein diets, protein competes for absorption with the medication. Big issue later in the course of the disease when people have less regular absorption. So the easy thing to do is just separate a protein diet, protein intake by an hour from your levodopa intake. So that's why I said take it with an apple, take it with a banana, take it with a piece of bread, take it with a cracker, so they don't get nauseous, which is very, very common with levodopa. But no need to restrict protein, just to separate.
Great. Well, can you talk a little bit about the duodopa, the pump, for people who are interested in that solution? How is that solution different, and why would somebody choose that over something like DBS? And then how long does that last?
So there's a pump, just like some people with diabetes, initially you take insulin, you just, inject yourself in your stomach. And then some people have an insulin pump that gives you continuous insulin so that based on your blood levels of sugar, so that insulin dose is titrated to your diet and your need. Similarly, there's a duopa pump or a levodopa intestinal gel, which the pump is a feeding tube inserted into the stomach. So it's just like a feeding tube requires surgery. And then it's hooked up to an external battery pack that pumps in levodopa continuously. This decreases the fluctuations and the variance in the dose. So high doses of levodopa, too high give you dyskinesias, and too low get you off slow periods. So this tries to keep people at a maintenance level. As you can imagine, most people don't want to have a feeding tube put into their stomach. So this is generally put for people with more advanced disease as a surgical treatment. Now, obviously, its risks, a feeding tube is much lower risk than putting a wire into your brain. So some people who aren't good candidates for deep brain stimulation or don't like the idea of having brain surgery done, they can opt to have a levodopa pump insulin, levodopa intestinal gel used as a surgical treatment, highly effective for a subset of patients.
Is it something that can stay in the stoma like for 10 years,
so,
or does it be replaced a lot? Or?
Yeah, so many people in Europe have been used for 10 plus years, and so it can be used for long periods of time.
Great. Somebody's asking and saying that their person with PD is spending their life savings on a vice. Aside from the dopamine agonists, what are things that you recommend?
Vice?
Like a vice, something not great. They're spending their life savings on something that's not great.
Yeah, so I would raise this thing about they on a dopamine agonist, and if they're on a dopamine agonist, I would reduce it and eliminate it. They don't have control. It's called an impulse control disorder, and if you gave me enough of dopamine agonists, I would probably develop some bad vices too. I have enough of them as it exists. I don't care to increase the number of bad vices that I have or that my patients have. So if they're on a dopamine agonist, they have compulsive shopping, gambling behavior. I've had priests with, all types of bad behaviors that are unpriestly. It is I don't know, crime's a strong word, but it's a sin for us to be causing these things in our patients. We should get them off these medicines, reduce them, put them on levodopa, put them on an Mao-B inhibitor. There are a bunch of other medicines that can be used to treat Parkinson's, amantadine, others. Punt, refer to a neurologist. Save yourself, save themselves, save their money. These stories do not end well. Okay.
From a physical therapist, are there any specific outcome measures to measure the functional ability of someone with Parkinson's?
Yeah, there are a bunch of the physical therapists know them better than I do. Let me see if I can pull up this article. So this is the study I was recommending to you about Tai Chi and Parkinson's disease. And, so I think, Mel, you can see my screen.
Yes.
So this is a study from 2012, and Tai Chi group consistently performed better than resistance training and stretching groups in the maximum excursion, and directional control. The Tai Chi group also performed better than the stretching group in all secondary outcomes and outperformed the resistance and stride length and functional reach. Lower the incidence of falls as compared with stretching, and they were maintained at 3 months after intervention. And the best part, no serious adverse events. But these are the types of things that can be measured. Physical therapists will have others, but these are some of the functional outcomes that were included in that study.
Great, and I'll share that study in our show notes when we send those off. An occupational therapist asks, besides exercise and task interventions that we do, what can you recommend for the best habit changes early on in the diagnosis? Because it's often hard to convince people to be preventative versus reactive. And that's a question we get from a lot of PT and OTs. How do they get their people to buy in? They don't feel like they're that bad. So why do I need to see a PT or an OT?
Well, they're going to spend the last 15 to 20 years of their life with Parkinson's disease. And the question is, what kind of quality of life you're going to have? You can, depending on how you want to say it, they're going to spend every Monday and Tuesday of their life, from the time they're born to the time they die, with Parkinson's disease. And if I were going to spend every Monday, Tuesday of my life, from the time I'm born to the time I die, I'm going to invest a lot in trying to improve my functional outcomes related to do that. So I would be hyper physically active. I told you I recommend at least an hour a day, and then I would do 2. And then I think I would be mentally active. So I would want to build up cognitive reserve so that I'm less likely to develop dementia, or that I have as many good synapses as possible in place before they start dying away. I would be really serious about my diet. We didn't talk on it, but Mediterranean diet can decrease your risk of developing Parkinson's potentially, and is likely beneficial for people with the disease. So I would do that. I would be drinking tons of water to reduce constipation. I'd be eating a high fiber diet to do it. I would probably drink more caffeine than I do if I had Parkinson's, because it can be beneficial in the disease. We detail, lots and lots of recommendations in here on what I would do. I'd read the book. If I'm going to spend 20 years with the disease. And it's not just me that spends the 20 years with the Parkinson's disease, it's my spouse who, if my spouse is going to help care for me, and my family and my friends. And I want to be as independent as possible for as long as possible with Parkinson's disease, if not just for my own benefit, but for those around me.
Great. Another occupational therapist who works in a hospital says that they often see patients with Parkinsonian symptoms, maybe after a fall or their bradykinesia, and they have a hard time getting the doctors to screen or refer to a specialist. What is the best screen or symptoms to mention that can highlight the need for looking for possible Parkinson's?
I would empower the patients. If the doc doesn't do it, just empower the patient. You can go to our website. You can tell them to contact me, and we'll see if we can take care of them, especially if they live in New York State. This is a very easy bedside test. And so if people do that, you and I should be able to do 10 finger taps that are big and fast without any decrement. And if people start going this and they can't do it, or if they get really bad on one side versus the other, that's a very easy bedside test to do. Open and close, twisting the hands. Otherwise, just taking a good history. Have you had big constipation? Have you lost smell? Has your voice gotten softer? Do you have trouble getting out of a low-seated chair? Do you have trouble getting out of a car? Do you walk slower than your spouse? Do you walk slower than you used to walk? There's hundreds and hundreds of questions that you can ask, and then soon you get yes, 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 yes. And if the patient doesn't say yes, 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 the spouse will go yes, 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 yes. And then it's self-evident and it's treatable.
Great. Let's see. I'm a researcher and also have a brother with Parkinsonian symptoms due to antipsychotic meds over 20 years. We can't seem to get the levodopa working consistently for him. He takes it every 2 hours. Any suggestions? And also lots and lots of people here asking if you will do consultations, if you're taking new clients and all of that kind of stuff. So what's the answer on that?
Yeah, so if you, if antipsychotic, you first thing you gotta do is reduce antipsychotic, and then second, end this antipsychotic. Because if you give levodopa and the receptor's already blocked, it doesn't matter. It's not going to work. So you first got to do that. If they need an antipsychotic, and some people need an antipsychotic, Seroquel, clozapine are least likely to cause Parkinsonian symptoms. Having done all of that, if that's due to the Parkinson's, that should treat it. If it doesn't, they could have antipsychotic medication induced and they could have Parkinson's, so you could do levodopa and you might have to titrate up. There are also other medicines. I don't like them. They're called anticholinergics. They have a lot of side effects, but if someone's young, they can help treat medication-induced Parkinson's. I tend to avoid them. I tend to try to do no harm. So do no harm, no antipsychotics, limit dopamine agonists, watch out for side effects, do no harm. Yes, so we are taking patients. They go to easy, probably PDs. Just email me at info@endingpd.org. If someone's got some info@endingpd.org, that's the thing. Price for referrals a book. If you get a book and you write a book review, I'll take it.
Good. I'm not sure if this, is the interference possible between DBS and loop recorder? I don't know if I'm asking the right thing.
DBS and loop recorder?
Loop recorder?
So the loop recorder, I think maybe they'll clarify. The loop recorders like measure heart rhythms, and so I think you can have a Holter monitor or something and DBS. So you can have DBS and a surgically implanted loop recorder, or but that's a good question for a specialist. Even like for that, I would even punt to my colleagues. But yes.
Right. So a couple of people have come to us and said they have spent years with misdiagnosis. A couple of them had said that they had peripheral neuropathy, and they just, the doctor didn't ask enough questions, I guess, to kind of get back the background. It ended up that the person actually had a sister who had Parkinson's. But why does that happen so often? Is it just a lack of knowing or is it because Parkinson's is such a big disease that has so many different pieces to it that it's hard to sort of delineate between other things?
I think the biggest thing is just, ignorance. And people say ignorance, I'm ignorant about a lot of things. Like if you ask me about what's going on in social media, I have no idea. But people are just ignorant, and clinicians, I'm ignorant about breast cancer. I don't know a huge amount about breast cancer, and that people are ignorant about Parkinson's disease because they maybe got 1 or 2 lectures on Parkinson's disease. Almost all of medical training, especially for the docs, is hospital-based versus almost all of Parkinson's disease happens in the community and happens in clinics. So you may not have even gotten exposed to Parkinson's disease. Before I did my Parkinson's disease rotation elective, I had seen maybe 5, 10 people with Parkinson's disease in a neurology residency. So I think people just aren't aware, and they're not aware of how really, 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 really common it is. They also think that it might be part of normal aging, and normal aging is not having a tremor. George Washington did not have a tremor. Ben Franklin did not have a tremor. It's not part of normal aging. Someone gets a tremor that needs to be evaluated because it's often treatable. And with softness in voice, and some slowness is normal, but slowness and shuffling of your feet and falls, those are not normal. So don't attribute that's just aging, that's just grandma with that. It could be Parkinson's, it could be treatable, and then can get better with inexpensive interventions, including exercise and levodopa.
Great. Some people are still have been told by their doctor that their doctor doesn't want them to start levodopa because they, I think, are still holding on to the older information that it was better to hold off. Can you talk a little bit about why that was initially the case and why that is no longer the case, and why it's important to start, or when you should start the medication?
There are lots of myths out there, some propagated by competitors to levodopa. So levodopa has been around for 50 years. It's a generic medicine. It's really cheap. There's no big pharmaceutical company making tons of money selling levodopa, so there's less education promoted on levodopa than our alternative treatments. Some people thought it was toxic. That's been shown to be not the case. And every study has basically showed that early levodopa helps over late levodopa and is beneficial. So unless someone's really, really early in the course of these and just wants to be vigorous in their exercise and wants to avoid all medications, or they get really, really nauseous and that's not treatable, if anyone's got disability associated with the disease, I start them on levodopa. Almost. It's almost everyone that does it. Now, again, some people really don't want to start medicines. Fantastic. We can do exercise and other things. Some people don't want to start levodopa because it does carry a risk of dyskinesias after long-term use and high-dose use. And so those people I might use an Mao-B inhibitor and a lot of exercise. But the vast majority of people will need and will benefit from levodopa and can tolerate the medicine. Even if they get nauseous and the like, just refer them to a neurologist. You can give them extra carbidopa and lots of other things to help out.
Great. An OT asks, if a patient mostly has cognitive symptoms and also has a diagnosis of Parkinson's, when should we worry about Lewy body?
So it's really hard because we're not even sure that Lewy body disease and Parkinson's disease aren't two of the same diseases. So in general, the textbooks will say cognitive impairment and hallucinations develop late with Parkinson's disease, but very early within the first year or so in people with diffuse Lewy body disease. The diseases are treated relatively the same. Problem is people with diffuse Lewy body disease or hallucinations, levodopa can make that worse. So you have to be more judicious in their use. If people really have cognitive impairment, Aricept, Nepozil, and some ribostigmine, Remenil are medicines that have been shown to be a benefit in those individuals. So those could be started earlier in the course. Again, being physically active, again, being mentally active, again, putting people in situations where they're likely to function well. People with Parkinson's disease, when they have cognitive impairment, and just in general, people with cognitive impairment do not do well at cocktail hours. COVID has got rid of cocktail hours, but it's very hard for people with Parkinson's disease or dementia to follow multiple conversations at one time, but they're really good on one-on-one situations and being oriented and giving them time. They have great, just like they have slow movements, they have slow thinking. So giving them time to respond. They may not speak as many words as I do per minute when giving this talk, for example.
Okay. Are there any common medications that doctors are prescribing for an unrelated thing to Parkinson's, something totally different that actually has side effects that look like Parkinson's?
Yeah, Reglan and Compazine. So I hope my gastroenterology and primary care doctors use these very sparingly for gastroparesis or stomach complications. Those are very commonly used. I think less common now. I think most people realize that those things can cause Parkinson's and can block dopamine receptors. Antipsychotics are by far the most common. So people are using them for Tourette syndrome. People are using them for depression. People are using them for a wide range of psychiatric conditions that may not necessarily benefit for them. Now, people with schizophrenia and the like, yes, clearly. But there are lots of people on these medicines who may not need them. Older adults are often prescribed them for sleep. That would not be a good indication in general. For antipsychotic medications, there also have a black box warning associated with increased risk of death in older individuals with memory difficulties. So save your patients, do no harm, put your hands in your pockets.
Right.
Save some lives.
Does anybody have another question or anything? You've got Dr. Dorsey here. Okay, yes. Can you speak a little bit about the differences in how Parkinson's affects men and women, and sort of how it shows up? Does it show up differently in men and women, apart from the percentage and exposure to the toxins and that kind of thing?
There are some papers on sex differences in Parkinson's. I must say, I've never done a really deep dive. Women tend to be less likely to get diagnosed, especially older women, and they often have less support than men. So the typical stories, man might be married and the wife brings him into clinic, versus the woman with Parkinson's might be a widow or things like that, and might be less likely to get diagnosed. There's some differences, obviously, around sexual dysfunction with Parkinson's disease in the two groups. Estrogen may be protective in some animal studies, mouse studies. It seems like estrogen might be protective in terms of developing Parkinson's disease. But the disease course is not dramatically different between the two. I know, to my knowledge, my colleagues will probably jump on me for not being as well versed as I should be.
Are there some common nutrient deficiencies for people with Parkinson's, and whether it's the medication or just Parkinson's in general, and any treatments for that?
Generally not. It seems like there's some vitamin B deficiencies that can happen perhaps due to levodopa. So you could take a multivitamin for it. In general, no. But that would be the one area between the two. And then I'm looking on sex-dependent differences, and I don't see huge amounts, but I'm still looking.
Okay, and we have an article. We'll definitely send in the link to that. A question about the prognosis. What symptoms should doctors, care partners, allied health professionals be looking at that are sort of a sign that it's progressing to the point of it's, could be fatal?
So Parkinson's is, I think, the 14th or 16th leading cause of death in the United States. And so people, I told you, live 15 to 20 years. And so if you've been diagnosed at 65 with the disease, you're going to be 80 years old, and Parkinson's can contribute to your swallowing dysfunction. Often leads to aspiration pneumonia. So people can have impaired swallowing function and can have pneumonia. Huge issue for speech and swallowing therapists. Thank you for all of you that work on maintaining swallowing function. Simple things, straws, chin tucking can be done to help. Falls is another big reason for people to die, and the complications thereof. Everything from head trauma to broken hip. So big things on physical therapists to do Tai Chi and yoga and swimming to maintain mobility and balance. Late things, psychosis can happen. And again, you might need hallucinations. You might need to back off on levodopa. People with advanced, like 20 years of Parkinson's, might benefit from lower doses of levodopa for uncertain reasons. Cognitive impairment, people can get demented late in the disease and have cognitive impairment earlier in the disease. So that's often late stage. Up to 25% of people with Parkinson's are in skilled nursing facilities. I think there's lots of things we can do to keep people out of skilled nursing facilities, especially in the age of COVID. We can provide care to people in their homes. We can do physical therapy. We can do speech therapy. We can do that remotely. And Davis Phinney has victory summits to end these training episodes so that we can help bring a care to more and more individuals with Parkinson's so they can live fuller, more independent lives outside of institutions. But recognizing that for some people, especially with behavioral problems, hallucinations, sometimes it does require institutional care.
Great, thanks. Well, we are running way out of time, and I'm so grateful for you to be here today, Dr. Ray Dorsey.